Hello, everyone, and good evening. We're running a little bit late, but I'm happy you're staying around for this NOVO NORDISK sponsored symposium at the Paris Hepatology Conference. It's called Coordinating NAFLD Patient Care, the Role of Hepatology and Endocrinology. My name is Jörn Schattenberg, and it's my pleasure to present today this meeting and introduce my co-speaker and endocrinologist's friend, I'd like to say, Professor Cyril Kasi. She's a professor of nutrition and endocrinology, diabetologist at the University of Lyon, and has an outstanding track record in the field, focusing on non-invasive tests and the management of these patients. Welcome, Cyril.
Thank you, John. Thank you. Good evening, everyone. We are very happy, and I'm very happy to participate in Symposium. I don't think I need to introduce John Schattenberg, but for those who doesn't know, he's a professor of medicine, a hepatologist, a director of the Metabolic Liver Research Program. He's well known in the field, very active in NAFLD and also in multidisciplinary approach, which is the topic of today. So good evening, everyone.
Yes, thank you, and glad to be here with you, Cyril. Let's start out. We have divided the meetings into the presentation into 3 meeting objectives, and it's going to be heavily influenced by 2 clinical cases that each of us is going to be presenting one. We'd like to discuss the actual burden of non-alcoholic fatty liver disease in our everyday clinics, but also in your clinics, and the importance that comes from that burden in terms of the multidisciplinary care. I think it's something I do see every day. I believe, Cyril, same holds up for you. We do need to work together here. There are strategies that we could use, and that will be the second objective of the meeting, to discuss these, because really the management of comorbidities and the reduction of risk for these patients can be achieved by working together here. And then, of course, there's room for discussions around collaborations between hepatologists and endocrinologists. And this is an interactive session. We invite you both to participate, ask questions, and join our thoughts of how to take optimal care for these patients. This is the overview. After this short introduction, I'll be starting out with a clinical case that we'll then discuss jointly and with your support. And then Professor Kasi will continue and present her case, which is going to have a little bit different twist and approach. As I said, this is interactive, so please send us your questions. We'll be monitoring them and have the opportunity to respond to anything that you might think could be important to the cases we are presenting, and we'll be looking forward to get your input on this. As you know, and as if you've done in the previous sections of this meeting, you can do so by through the website by sending it through the web page. So let me get started. The importance of coordinating NAFLD care. And again, I try to build this around a case that I've fairly recently seen in my clinic. In general, I think most of us agree that non-alcoholic steatohepatitis and NAFLD is a pretty prevalent disease. The global prevalence in the general population is said to be between 25 to 30%. NASH, the inflammatory subform, the one that produces complications, fibrosis, cirrhosis, but also HCC, is globally somewhere around 1 to 5%. Now, it's difficult to name that number because if you insist on biopsy to define non-alcoholic steatohepatitis or steatohepatitis, of course, these studies were not previously done. But we're seeing increasing uptake of very good non-invasive tests that we can use to estimate these numbers. And of course, based on the increasing prevalence of metabolic comorbidities, we cannot expect that this is going to go away. Rather, on the contrary, there's going to be more cases over the next years. And I'm just out of a conference from the American Association of the Study of the Liver Disease, and one of the speakers was actually highlighting this and saying that he does not believe that there will be a tide turning here, and we're going to see a decrease of cases anytime soon. So what is non-alcoholic fatty liver disease and NASH? And this is, in the end, a very slowly progressive disease. As the hepatologist, we like to stage the disease based on the severity of the fibrosis, so the amount of scar that's in the liver, separating early histological stages, F1 and F2, from the advanced pre-cirrhotic stage, F3, and the NASH cirrhosis cases, F4. Now, not every patient that has fat in his or her liver will go on to develop cancer or cirrhosis, but it's a condition that predisposes to this risk and for sure increases the morbidity and mortality. Overall, the incidence of hepatic complications, endpoints, but also hepatocellular carcinoma and death related to NASH is going to increase, expected to be increasing over the next years 2 to 3-fold. And the focus on the fibrosis stage, the underlying fibrosis stage, the reason for focusing on it is pretty much exemplified on this slide. You can see that in the early fibrosis stages, the added risk of experiencing liver-related mortality, but also all-cause mortality or cardiovascular events is not very high, while you move towards the advanced disease stages and F3 pre-cirrhosis and F4 cirrhotic stage. These are the stages where we do really see an increase in the mortality, and in particular liver-related mortality, of course, but also all-cause mortality. There's an increased rate of cancer, colorectal cancer, and there is importantly increased rates of cardiovascular diseases. So to assess the disease stage, the severity of fibrosis will help you to risk stratify your patients and identify those that are more likely to experience events. And that brings me to my first case. This is Eric. Eric is a 66-year-old male. He's been treated for diabetes for quite some time now. He's overweight, a former smoker, and has a history of cardiovascular disease. This is actually how he was introduced into our hospital. He's on medications for type 2 diabetes, including insulin. He has some arterial fibrillation and therefore receives a direct anticoagulant and a beta blocker, as well as some additional medications. Now, the cardiologists refer these patients to me for fatigue and elevated liver enzymes. And let's see what the clinical workup looked like. These are the lab tests of Eric. And you can see that the diabetes with an A1C of 8.1 is not perfectly controlled. Sodium 134 is not a problem here. AST and ALT are elevated. Bilirubin is slightly elevated, and platelets are borderline normal. So when I talk to my cardiologist and like to discuss whether a patient should be referred or not, I'd like to introduce a test that we're going to be discussing more on more occasions today, which is the FIB-4 score. The FIB-4 score combines platelets, age, and the two aminotransferases, AST and ALT, to predict the risk of advanced fibrosis or rule out the risk of advanced fibrosis. And the FIB-4 score here is in an intermediate zone, so not truly helpful, but it does guide us in terms of which patients are at increased risk, and he clearly is above a lower cutoff. So this would be a patient's, when you're trying to establish referral pathways, that would have ticked that box and would have actually been referred for further workup. So something I did here also, because the labs are abnormal, is order an ultrasound. And the screening ultrasound of this patient actually revealed an hypoechogenic lesion that you can see on this ultrasound image. And we did transient elastography to assess liver stiffness. And the value here was 14 kilopascal, which is clearly elevated, potentially in the range of cirrhosis, but not at the high end of the scale. So the worrisome feature here is, of course, this hypoechogenic lesion, and we did do a CT and confirmed that this lesion has arterial hypertension and venous washout and therefore already qualified as hepatocellular carcinoma. We went on to obtain a liver biopsy, both of the non-cancerous tissue and the adjacent tissue, and were able to establish the diagnosis of NASH cirrhosis with HCC. This is, of course, something that not every patient with NASH develops as a complication. However, we do see a dramatic increase in the prevalence of HCC in patients living with NASH. And overall, the number of patients that present with HCC are more frequently diagnosed with NASH. The risk of HCC is even elevated in non-cirrhotic patients, and this is something we know as hepatologists. Inflammation drives this cancer. We see that in hepatitis B, for example. Hepatitis B has much more higher rates of HCC compared to NASH, but still, in the non-cirrhotic NASH cases, there can be HCC, and based on the high numbers we are seeing globally, this is of course of concern. And it's important to be remembered that HCC is estimated around 90,000 cases every year in Europe. Let me revisit the history and the course this patient takes. And I think then, Cyril, this will also be a good point where we can already start to discuss and exchange some thoughts on this. This patient has been under care with an endocrinologist, and he has been managed for his type 2 diabetes. Again, the management maybe was suboptimal with the A1C, but he was diagnosed in 2011. He does have some alcohol consumption, which for most of my patients is true, but it qualifies in the range where we would consider this as non-alcoholic. In 2016, he developed AFib, and this was the time point where he is actually getting into contact with a cardiologist. And going back through the medical records, I recognized elevated liver enzymes right here for the first time, even in our hospital system. That was as far as I could go back. We did have an ultrasound back then, which showed steatosis, but really no additional referral was triggered based on that exam. In 2020, he had an episode of symptomatic heart failure and underwent surgery. There was signs of anemia already, and liver enzymes maintained to be elevated. And then in 2023, this is the first time the patient was actually referred with fatigue. And you see from this course that probably cirrhosis developed somewhere between 2016 and 2020, or maybe 2023. And we probably didn't pick this up at multiple levels of the care for this patient, which was again, within my hospital system even. So let's start to think about this case, and this is the opportunity for you to participate through the poll, but also to ask questions on the online platform. So please start polling, and while our listeners are taking that poll, Cyril, I'd like to maybe reflect with you together on this case, or just get your thoughts and thinking of what I've just shown.
Sure, exactly. I think there's many things we can say about this clinical case, which is obviously something that most of us have seen, and you see in your clinics. You see a patient with risk, as you showed us. He has multiple risk factors of metabolic disease. He has type 2 diabetes. And obviously, he had elevated liver enzymes since quite a few years without any worries about his liver specifically. So I think this speaks very well to the lack of awareness of the disease and potential severity of the disease. And hopefully now it's improving, and there's more and more awareness about NASH and potential progression to advanced fibrosis and cirrhosis. But we cannot help think that it's probably we could have catch or identify the patient earlier in this journey to make sure that we could provide at least optimization of the treatment. I'm also seeing that the diabetes is not well controlled, so I think it would have been interesting to maybe optimize the drugs and the treatment for this patient. So I don't know what you think, John, about the detection, early detection of HCC, for example, and the screening pathway you could have implemented in your clinic earlier?
Yes, so I think you raise a number of important points, and in retrospect, it's always easy to be finger pointing, and I don't think we want to be finger pointing here. But of course, I would recommend, and that's what the current guidelines actually say, to screen a patient with type 2 diabetes for the presence of advanced fibrosis. And there's a number of tests that we can do. I've mentioned the FIB4 test, which in my hepatology clinic doesn't play a big role. But I think for these patients that are managed outside of hepatology, could have been a good thing to do so. Now, I don't know what the FIB4 looked like some years ago, but it's for sure a tool that's useful here. Do you use this at all, Cyril?
We use it, but to be honest, and exactly, we have started to using it, I think 3 years ago. So obviously, it could have happened to one of my patients as well in my clinic in 2016. So I think really this test may be helpful. Maybe we can look at the result of the poll. I think that regarding the way we could have we could have taken sooner to identify the risk of HCC. We have the majority of the audience that says that earlier referral to hepatologist, 63%. So totally, I think we all agree that an early referral would have probably at least make the patient in a pathway where he would be treated for the liver specifically and screened for HCC. A few 38% said calculating FIB4 annually following type 2 diabetes. So I think there's not a consensus here, and maybe this would lead to more question. And if someone in the audience has comments on why they think it should not be calculated annually, this would be very please don't hesitate to comment on this sentence. And finally, surveillance for HCC every 6 months if NASH with advanced fibrosis, 38%. So it's still debated, right? I think, John, that we don't have clear guidance for screening for HCC in patients with, advanced fibrosis, F3. But maybe definitely if he had been diagnosed with cirrhosis, he could have been entered in a pathway.
That's exactly true. And there's actually one of the questions we get online too, based on the fact that the patient was diagnosed with diabetes, should he been under surveillance for his liver? So to answer the surveillance for HCC first, in patients where there's no cirrhosis established, the cost-benefit ratio is not clear. German guidelines are very liberal. They offer that you could do this. European guidelines, in particular those that are operating on a very cost-effectiveness calculation, cannot recommend this currently. If a patient has cirrhosis, screening should be performed every 6 months. Now, the challenge in the obese population is, of course, the availability of very good ultrasound surveillance. But I would not back off here. And again, as we see, it's reality that our patients with NASH develop cirrhosis, HCC. The cirrhotic phenotype here is not very strong in this patient. He had borderline thrombocytes. The stiffness was 14. So bilirubin just starting to be elevated. This is not end-stage cirrhosis. This is probably early cirrhosis, and still he developed HCC. But in these cases, screening is then recommended.
But I have a question, John. Would that make a difference if you detect early lesion of HCC, and if he could have maybe be diagnosed earlier? I mean, if he could have been detected earlier in just a basic ultrasound, do you think the prognosis of the patient could be improved in that case?
Yes, good point, Cyril. And yes, we have very effective treatments for hepatocellular carcinoma, in particular when detected in the early stages. Next to ablative therapy, there is a transplantation option for these patients. Even in advanced cases, we're seeing very effective immunotherapies. And the sessions today during the day focus on HCC, so we don't have to recap that. But there is a lot of treatment options, and it is of clear advantage for the patient to be diagnosed early.
So that's really something, probably a key take-home message for us to bring and to at least spread to the diabetology field. I think we can definitely understand that it's worth detecting a patient with advanced fibrosis and cirrhosis, because we could improve his prognosis and potential liver-related events that may happen in the future. So I think this is really important. I'm a little bit surprised in the poll that no one thinks that the paroxysmal atrial fibrillation should have trigger screening or referral to the hepatologist. What do you think about this proposition?
Well, we currently say that patients with type 2 diabetes or risk factors should be screened. And for sure, atrial fibrillation is a cardiovascular disease and not necessarily a risk factor for NAFLD, but patients with atrial fibrillation also exhibit metabolic syndrome very frequently. So I would probably state that the metabolic syndrome type 2 diabetes should trigger a screening for advanced fibrosis. In this case, this is not HCC, but it should be tested. Those patients should be tested to see if liver disease is present.
Yeah, and correct me if I'm wrong, but I think that there's a epidemiological study that shows an association and a significant association in patients with NASH, especially in diabetes, and the development of cardiovascular disease, including arrhythmia and atrial fibrillation. So it could
absolutely, and it speaks to the comorbidities these patients have. Again, this is not a liver disease happening in isolation, but something where many specialties are actually involved.
Many physicians may see this patient, and so everyone should be aware that probably we need to pay more attention in the liver.
Yes. So in the interest of time, I think we're going to move on, and I'm going to hand over to you, Cyril, for the next session. Again, as a reminder, you can submit your questions online. And now please hand over the control to Professor Corsi.
I'm taking the control, thank you. And so in the next part of this symposium, of course, we're going to emphasize the need and really how we can work together in a multidisciplinary way and hopefully in harmony in order to improve the clinical management of the patients. So of course, we've already tried to talk a little bit about that, but just wanted to remind you that NAFLD and NASH is a metabolic disease and is also most of the time associated with other metabolic comorbidities and complications. Obesity is very strongly associated with NASH. You see that more than 82% of the patients with NASH do have obesity, and doesn't need to be very severe obesity, just obesity grade 1, BMI greater than 30 kilogram per meter square is already a trigger that make us suspect at least NAFLD. There's also, of course, dyslipidemia, and it can be all type of dyslipidemia, hypertriglyceridemia, mixed dyslipidemia, or just elevated cholesterol. All these characteristics are associated with NASH. Of course, the metabolic syndrome is also strongly associated with NASH. And type 2 diabetes, this is the point of view of hepatologists. You see approximately that the patient with NASH, among them, there are 47% who has diagnosed type 2 diabetes, but most of them do have insulin resistance. And the last comorbidities that is very strongly associated with NASH is hypertension, with a prevalence of 63% in these patients. So really you see that obviously already there's many physicians that could deal with this type of patient, cardiologist, nutritionist, endocrinologist, diabetologist, and I think we need to be all involved in the clinical management of this patient. We would like to highlight and just to remind the audience that when we are talking about case finding and try to identify the patients that are progressing and that have a higher risk of develop the progressive stage, which is NASH, and you know, all of you knows that NASH is the driver for the progression towards fibrosis. This is exactly what happened to the patient that John has presented just before. And in that case, we clearly know, and it's really well demonstrated, that the presence of type 2 diabetes but also the presence of obesity. And most of the time, the two conditions combined together increase the risk of developing NASH. And that's the reason why we know that we need to target in priority this high-risk population, so that we make sure that at least we could diagnose and screen for the presence of NASH and the presence of advanced fibrosis in this high-risk population. So you see numbers in the screen. We have data from meta-analysis performed in a cohort of patients with type 2 diabetes, even though, as John said, it's really difficult to perform epidemiological study regarding NASH because there's not a lot of studies that perform a liver biopsy in these patients, but the prevalence of NASH in type 2 diabetes is approximately 37%, and it's 18 times, and these patients are 18 times more prone to develop NASH. And you see that the prevalence of obesity is the same. We estimate that there's approximately 30% of patients with obesity that develop NASH, and this is 20 times more prone to develop NASH than the general population. So clearly here we have high-risk population, and I would like to then introduce you these comorbidities and discussion around the clinical case. I want to talk about Gabriel. This is a patient that I've seen in my clinic a few months ago. He is 61 years old. He has been recently diagnosed with type 2 diabetes. You see that the HbA1c is still not optimized and above the target, 8.5%. He does have obesity, and he had obesity before he developed type 2 diabetes. This is one of a major risk factor. As you see, he has grade 1 obesity with a BMI of 32.1 kilogram per meter square, and he presents all these metabolic comorbidities. He has dyslipidemia, hypertension, and obstructive sleep apnea. I will focus, no, we will just based on this very simple clinical case and presentation of a patient that we see in our daily practice in endocrinology and diabetology clinic. We would like to ask you the question and the poll. So please, can you tell us how I should screen, and all my colleagues should screen Gabriel for NAFLD and NASH? We will let you the time to answer. You see that there's many non-invasive tests that are proposed, and maybe, I don't know, John, if you want to comment a little bit on this presentation and clinical case.
Yes. So for our tech, maybe restart the poll in case it was not started correctly. I think this case is pretty similar to the one I showed. He's younger and maybe earlier in the road. And I think you are here at a stage where where my patient was maybe 2011 or 2016, where we are still at a point that we can make the diagnosis of liver disease earlier. I think it's a patient with type 2 diabetes as a risk factor for NAFLD and NASH, so he should be screened for the presence of advanced fibrosis. And as you said, the metabolic comorbidities, we know the more metabolic comorbidities a patient has, the more likely he also exhibits relevant fibrosis. And the screening algorithm that you're asking here, that we're polling on, is you offer 4 opportunities. I think do nothing. We can start to discuss this. I think the poll is still running. To do nothing is probably not an option from what we saw previously. I think I would like to encourage you and colleagues out there to start thinking about liver disease and assess these patients that are at metabolic risk. And now we have 3 non-invasive tests being displayed here. The liver enzymes and the FIB4 is probably the most cost sensitive. Again, it combines AST, ALT, AH, and platelets. And it's something you probably have in your clinic anyways. Is this something you have to get an extra lab for, or do you look at these labs?
These are the
care?
labs that are already currently done in a yearly checkup of a patient with type 2 diabetes in the clinic and in the department. So this is easy. I think, and I will talk to that a little bit later when we discuss about the pathway. The key thing is just you need to encourage the endocrinologist to calculate this score. It is very simple. There's calculators online. But the major change has happened in my department when we talked to the biologist, and they implemented an automatic calculation of the score directly on the lab results. In that way, it pops up, and there's also an explanation on the threshold, and it makes it easier. Even if you don't think about it, it comes to you automatically, and then it makes you question, okay, I see that the result is above a threshold, and I should probably do something about it. So I think this is really important.
Yeah, so this is interesting because you said I have those tests anyways, but the FIB4 is complicated. It has like, I have to calculate something and I don't have time for this in my clinic day. Exactly. So then you went to your lab and told them, well, just calculate it for me and report it automatically. And I think that's a very good solution, a smart way to start to assess this in a regulated manner. And actually one of our online questions we got here, and thank you for this, is there's probably not enough hepatologists to take care of all these patients with diabetes. And again, this is not a disease. Diabetes is the main disease in your patient here. And we do not have hepatologists to see all of them. So the automated FIB4 assessment could be a very smart way to actually assess the risk of this patient.
So if we go to the poll results, I don't know if everyone has had the time to answer, but let's just touch base on the results. Hopefully, there's nobody in the audience says that we should do nothing. So that's very good news today in 2020. There's a huge majority of the voting saying that we should measure at least liver enzyme and FIB4 calculation. No one is thinking about the ELF test. So it could be useful. This is something that it's not very well implemented in every healthcare system. We do have lots of experience from our colleague from the UK. Do you use the ELF test? Because personally in France, it's still a little bit difficult to access to this test, and I don't really have the experience of this test. So
yeah, it's an interesting test and I can access it, but it's not in our routine assessment, and it's something the patient would have to pay, or the hospital in addition at this time. On the other hand, it's a test that actually has prognostic value, and we have not seen so many. So I think when evidence starts to pile up over the future, the ELF test might become of a higher importance. I think for the screening of the patients living with type 2 diabetes, if you're not in the UK, the FIB4 is a very effective measure. And even in the UK that's used, the ELF is probably a specialist's test at this time.
All right. So, and then there's a 17% that also suggests that endocrinologists should perform a fibroscan. This is also interesting. I don't know if your endocrinologist does prescribe or refer to a liver stiffness assessment using a fibroscan, or how is it set up in your practice?
Yeah, we of course the hepatologist has the fibroscan. My hepatologists regularly don't have a fibroscan, and this is the technology I think is fairly easy. It's a ultrasound based stiffness measurement, as you know. The hurdle is to get to know the test a little better, and I think you're using it in your clinic. Is that correct?
Exactly. So we do use it. We have a fibroscan in the endocrinologist and diabetology clinic. I think it's really depending on the setting, but to our experience, I think one of the common in the question was, if you do the FIB4 for everyone, and there may be an overflow of patients, and the worry that hepatologists may not be able to see all these patients, and actually putting a second line test, and we'll see that it's actually what is currently recommended before the referral to the hepatologist really helps to screen the right patient and make sure that the one that you want to see, the one with severe disease, actually goes to the hepatologist. and enable us to keep the one that obviously doesn't have advanced fibrosis or even significant fibrosis. So for the sake of time, maybe we should go on in the clinical case. So just I think really, and I'm sure everyone is now convinced that endocrinologists and diabetologists can really have a role in the early detection of NAFLD/NASH. We are the one who sees the patient, and we see them yearly for the checkup. So that makes it easier maybe. And as we said, also, we are used to do a really check up on a lot of organs. We check the liver, we check, the kidney, the eye, the heart, cardiovascular disease. So it's not something that is impossible for us to implement a new checkup and check on the liver and with using non-invasive tests. But what really we need to do is to understand this test, knows what they are useful for, and how to interpret that. And I wanted to go through the most recent clinical practice guidelines suggesting the use of a non-invasive test for the patient screening referral. I think it's very interesting, and this is also bring a lot of improvements in the way we can take care of the patient. Here we are showing you the EASL clinical practice guideline that has been updated in 2021. But I'm sure you're aware that there's many clinical practice that has been implemented in the last 2 years from the GI field in the US with the ASLD, the most recently, the Gastroenterology Association as well. But the very exciting thing is that also the diabetology field is embracing these recommendation and guidelines. And early in January, we had the American Diabetes Association guidelines that release the same pathway referral as well, and the Endocrinology Association in the USA. So I think it's really encouraging, and everyone does agree that we need to screen for advanced fibrosis. So let's just go over the current EASL clinical practice guidelines, and they basically all the same. They all agree on the same thing. There's a few differences, but the non-invasive tests that we should use are the same across all these guidelines. So of course, we've already said that a patient that has is at risk of chronic liver disease, such as type 2 diabetes or obese patients, should be screened. There's here a box saying that if, of course, we have any suspicion of other causes of liver disease, such as alcohol, HBV, HCC, or a familial history that makes us suspect something very specific from the hepatology field, we should refer the patient, and there's no question about that. And then it tells us that we should check on the liver of the patient using AST, ALT, and the platelet counts, and the calculation of the FIB-4. And
Cyril, if I just cut in here as a hepatologist, the mentioning of other liver disease to me is always very important. And I can tell you have talked to a lot of hepatologists that you highlight this here, but it's important to be remembered that even the elevated liver enzymes can be a well-treatable HBV or HCV infection. So I think it cannot be underlined more that this also has to, even in a patient with diabetes and obesity, this of course should be checked once.
Yeah, that should be checked, and it could be also one of the reasons for elevated liver stiffness. If you have not any suspicion of this, then calculate the FIB-4 could be really useful. And I think what is also very important in these guidelines is that now we have clear threshold and cutoff that we should use. And this is important because you know that the FIB-4 has 2 thresholds and a gray zone. And in the past, it has been a little bit confusing for us endocrinologists. What should I do? Of course, we understand that at the low threshold, below 1.3, there's a low risk with a very high negative predictive value of having advanced fibrosis. And now these guidelines are clear. Below 1.3, no need for referral. You can also be very reassuring for the patient that there is no suspicion, or the probability of having advanced liver disease is low. But of course, you still may want to manage the patient in the metabolic way, and lifestyle modification should be counseling, and we are advised to retest the patient 1 to 3 years. And I think this probably would need to be refined in the future. It's not very clear, 1 year, 2 years, 3 years, but at least we know, don't forget the patient. You need to retest the patient as well. And the good thing also is that there's no any other threshold. It's either below 1.3 or higher 1.3. And if it's the patient goes in this range greater than 1.3 in the FIP-4 score, then you need to tell your patient that he has intermediate high or high risk. There's a suspicion. It's not certain, but a second line test is needed. And in this guideline, the second line test that is proposed is to perform a liver stiffness by a transient elastography. We can potentially use a FibroScan to do so. And again, the thresholds are very clear now, and this is also very helpful for the field. The threshold is fixed at 8 kilopascal. If the patient is below 8 kilopascal, you can reclassify your patient into the low risk categories, and it doesn't really need to be referred in a hepatologist. Whereas if the liver stiffness is elevating above 8 kilopascal, again, we need to go further. The patient definitely need to be referred to a specialist and to the colleagues hepatologist. And so there's multiple possibilities here depending on the healthcare system. We can, and the guidelines propose that we can do third line patented test, potentially the HELP test. We have other patented tests, such as the Fibro test, Fibrometer, so many possibilities. And if there is a concordance of the test, you may not need a liver biopsy, but if there's any doubt and you need to go any further, then the discussion should happen with the hepatologist whether it's worth to perform a liver biopsy to have a clear diagnosis of the severity of the disease. Or if the patient is certainly already having F3, F4, as we said, he can enter in the screening pathway and will be taken care of in hepatology. So this is really what is recommended, and as I said, by every guidelines, and again, the threshold as well are the same across all the guidelines in diabetology, endocrinology, and hepatology recommendation in Europe and in the US, which makes things very clear, at least in the mind on a diabetologist and endocrinologist. What should I do? I just follow this algorithm, and now I know if I need to refer the patient. So I think that we have a question popping up regarding the cutoff to consider in NASH setting with shear wave elastography. I don't know if you want to jump on this, John?
Yeah, that's you mentioned transient elastography. There's a number of elastographic applications that can be used, including the shear wave elastography. I have to say my personal experience with shear wave is limited, and I cannot give you the right number for this, but there is a number of ultrasound-based stiffness measurements which can be used. I think the reason why a lot of the transient elastography is mentioned, that there is a lot of data that has been generated. Nonetheless, other technologies are useful here too.
All right. So let's go back to Gabriel, my patients that I've just presented it earlier. So we know that he has multiple risk factors. We definitely are convinced that we need to check for the liver status, and I'm just focusing right now on the labs performed in order to screen for the liver. You see that he has moderated elevated liver enzyme, AST50, ALT43. The GGT also is elevated, 71 units per liter. This patient doesn't drink. We have asked him. The platelet count is normal. The albumin is normal. And you see that he has just a dyslipidemia with elevated triglyceride. So we did calculate the FIP4. And as you can see, it is not very, very high, but it is above the threshold of 1.3. And that's the reason why we went further in the department. So the patient had an abdominal ultrasound that show hepatic steatosis and no other lesion, no dysmorphia, and no signs of portal hypertension. And as we said already, in the department, we have access to a fibroscan assessment. So the patient underwent a liver stiffness measurement. And as you see, the liver stiffness and elastography was pretty high, 11.8 kilopascals. So I think based on this, we had, based on this exam and assessment, the patient was referred in a liver specialist. We have implemented a very specific pathway with the hepatologist in the Lyon University Hospital. We now work in an institute, and so it's very clear. They know that we are doing this type of assessment. They know we are equipped with the fibroscan, which makes it very easy when we want to refer the patient. They know that they're gonna receive a patient in the consultation that already had all the labs and the FIB4 and the liver stiffness assessment. And so additional test has been run in the liver clinic, especially a fibro test, which was classified as F3, a little bit discordant. We may have suspected cirrhosis potentially in the presence of elevated liver stiffness, but not sure. And the liver biopsy finally reveals that the patient had NASH and stage of fibrosis F3. We use the SAF score in France, so with steatosis grade 2, activity 3, fibrosis stage F3, and the NAS was 5. So clearly we see that the patient had already advanced fibrosis, even though the presentation and the labs were probably not very high, and even the FIB4 was high, but was not really high to put the patient in a very high probability of having advanced fibrosis. So in this type of setting, and I'm sure there's some, you may already have this type of question from the diabetologist and endocrinologist, thinking, okay, what's the use and why should we screen the patient? What would be the benefit for the patient, but also for the economic health system and the impact of this risk stratification? So we do not have many data in this type of risk stratification performed in diabetology, but there are studies, and we are showing you the results of one study that has been performed in the primary care. And the top line results are that no matter what the stratification you may use, it can be either a FIB4 score followed by the ELF score. It can be a FIB4 score followed by a transient elastography. It could be an ELF score in just performed in primary care, or directly a transient elastography performed in primary care. When you compare all this referral pathway, at the end of the day, what you see and what you observe is that you significantly increase the diagnosis of advanced fibrosis. And this is also very important. This is a disease that remains for a long time asymptomatic. And even the patient that John and presented us earlier had a little bit of fatigue and asthenia, but he was not really complaining about his liver. So we may miss it if we don't look at it. So definitely you increase the case finding, and you will increase the awareness of the patient having advanced and severe liver disease due to an NAFLD NASH. The thing is also that once the patient are really taken care of, you decrease the total healthcare spend, and finally you also will decrease the referral and the hospital referral. So there's a benefit obviously for the patient, and we already discussed that, but there's also benefit in the global health system that speaks to the systematic screening of NAFLD. And finally, if we look at the global picture, and this is really important, and I just wanted to highlight the very recent guidance, updated guidance from the ASLD for the multidisciplinary management of NAFLD. This is key, and this is really important, and John has done a lot of also work in this field, trying to put together a physician from the nutrition field, physician from the gastroenterology field, and also the primary care provider that are the heart of the system in most of the healthcare system. We need to all together make sure that we we do screen and we do take care of the liver assessment using the tests that are available in our setting. So probably FIB-4 in primary care. In diabetology, if you have access to elastography, if you have access to liver stiffness, you can go for it. And also, once the patient is diagnosed and you see that there's a concern regarding presence of NASH or the presence of advanced fibrosis, even though there's no approved therapy right now, there's many things we can do. You can really try to refer the patient to a nutritionist to try to assess the dietary habits, try to change the diet, change the lifestyle, improve the physical activity, and all these things together may have a beneficial effect on the liver status of the patient. Of course, on the hepatology and GI department, there's the comprehensive liver risk stratification, where it goes into detail what stage of fibrosis is there NASH, should we screen for HCC and manage all these potential comorbidities in a liver standpoint. And we know also that there's many opportunities today to be enrolled in a clinical trials if the patient is interested. And also don't forget the cardiologist, and we know that this patient, the first cause of mortality in this patient are cardiovascular disease. So make sure that the cardiovascular risk factors are really well managed and controlled, and the patient are screened for cardiovascular disease. And weight loss management is also very important. Beyond lifestyle intervention, there's a new era open up for today with new medication, bariatric surgery, intervention that we can offer. So many things we can do all together and try to find the best management of the patient. So to close this presentation and this case presentation, I think my take-home message would be that, of course, and I think we're all aware of that today, the patient with type 2 diabetes and obesity need to be screened, and a FIB-4 is recommended to assess the presence of advanced fibrosis. We need a second-line test, and the one that is currently recommended in the guideline would be imaging liver assessment using transient elastography. And in order to implement this pathway and to make sure that everything works with a flow that is smooth for the patient and for the physician, we need a close collaboration. We need to optimize the clinical care, introduce more guidance, and talk to each other, because there's a lot of awareness coming up regarding NASH, but also we need to be more educated on the NITs test, and we need to know how to use the test, which are the thresholds, and how can we refer. So I'm sure you have lots of comment and discussion regarding this pathway referral. John, can you tell us a little bit about how you would like us to refer? Do you have this type of implementation in your clinic?
Yes, so this was a great oversight, Cyril, really. And we actually do have a question around the referral. There's a few minutes left, not too many. Please enter your last questions that you might have. One question we got here, Cyril, was would ELF be a useful test in addition to FibroScan? And I think today's point is, and maybe you can advance the slides on our behalf, just one slide forward, is use what you have. I think it's important. We're seeing both cases. Your case had very advanced pre-cirrhotic disease already. I mean, this patient will probably develop cirrhosis in a short time, or let's say over the next 5 to 10 years. And my patient had HCC. So if we use the tests we have today, we can identify patients at risk. FIB-4 is probably already very available in most settings, as you said, implemented into the lab testing. You get an automated report. I thought that was a very smart way. We haven't done that in our hospital, and it's something I've been thinking about, but haven't just succeeded to implement that. And I, as you mentioned, I think it's very important to work together. Maybe advance one more slide. I think the reason for working together, as you highlighted here, is the multimorbidity of these patients, and even today we can optimize the management on multiple aspects. Many patients that come to me and have severe metabolic risk are, for example, not on statins, and I believe you like to have your patients that are with cardiovascular risk on statins. So those are the things where we really can work together. And the one question we have coming up in the chat is also what are the barriers to optimal management? And I think it's just around that. We have to start talking to each other and maybe make the penetration of patients going one or the other way more easy. And those non-invasive tests, for example, the FIB4 could help us to do so. Maybe one more slide, Cyril.
I just wanted to add regarding the barrier. Of course, we talked about awareness. I think there's more and more awareness, but now we need really to do more effort on education. And the new guidelines are here, but we know it takes time to implement them in clinical practice. So really try to tell which are the thresholds, which cutoff you want to use to refer the patient. And also potential treatment. We know we hear that from our colleague from the diabetology field that there's no treatment today, but there's so many things we can do. And I think this is really the coordinated multidisciplinary care, John, that we can propose. There are so many things we can do for the patient, even if there's not approved treatment so far, and we expect some in the near future. So this could be also very important.
Yes, and this is a very nice slide to show what we think could be the best management, because again, my patient was really a cardiological patient from the beginning and then developed cancer. Understanding what the other disciplines are looking at and what could be critical for the patient, and we have to harmonize that, this could be the best thing here. So this brings us to the end of this, Cyril. This was a lot of fun. Thank you very much. To our audience, thank you for staying with us, albeit running a little late. Please do give us feedback on this meeting using the online evaluation form. It's been a great pleasure. I learned from you, Cyril. We didn't have time to talk about in-depth management, but I think this is something that feeds into that multidisciplinary aspect. I cannot know all the details of the diabetes management that might be required. That's why I like talking to you so much. And on the other hand, I salute to you that you have already implemented FIB4. It would be my recommendation that you are thinking about this in your department too, or from wherever you are listening to us. I think it's an easy way to identify risk patients and could avoid a number of cancers like I have shown you in my patients potentially. By optimizing the management. And with that, not sure you want to close off yourself and say something. For me, it's been a pleasure, and to all of you, a very good evening and the rest of it.
Thank you very much, John. Thank you to NOVO Nordisk for supporting this symposium. And for those who want more information about in-depth management, there's a full session tomorrow. So please join the Congress tomorrow on the NASH specific day, and we'll talk more about comorbidities management tomorrow. So have a good evening, everyone.
Thank you. Bye-bye.